photo from the UK, where you can see that we have a very firm London eye on COVID. My name is Shirley, and I am a consultant haematologist and associate professor at University College London, where I work at the University College Hospital and the National Hospital for Neurology and Neurosurgery. We have a specialised service for Waldenström's at our hospital, and also have a special interest in the neurological complications. And I'm pleased to say that I do a weekly clinic with a colleague of mine, Professor Michael Lunn, who is a specialist in this area. So Bing-Neel syndrome was first reported by Jens Bing and Axel Neel back in 1936, where there was an association made between hyperglobulinemia and central nervous system symptoms, including what they reported was paresthesia or pins and needles, headaches, problems with gait and paralysis, and brain infiltration by lymphoplasmacytic cells was identified. So people often wonder, how does Bing-Neel syndrome actually relate to WM? I like to use this Venn diagram to try and illustrate the relationship. So WM is the condition of lymphoplasmacytic lymphoma, typically in the bone marrow, but also in other organs such as the spleen, or in areas such as the lymph nodes, or even in so-called extramedullary areas, places where these cells don't normally exist. And it is, of course, characterized in most people by the presence of an IgM paraprotein. There is an overlap between Waldenström's and peripheral neuropathy, because the IgM paraprotein can induce problems with the peripheral nerves. But also you can get infiltration of peripheral nerves by Waldenström cells, LPL. You can also get other complications such as amyloidosis or cryoglobulin, which can lead to damage of peripheral nerves. So there is that overlap, which is well known. But there's also this overlap with Bing-Neel syndrome, where the cells infiltrate the central nervous system. In our experience, you can also, obviously, Bing-Neel and peripheral neuropathy problems can coexist. And in some patients, there's a bit of everything, actually. So they are associated, but the presentation can come from different angles. Some people may just have the Waldenström's expression of the disease. Some may have neuropathy in Waldenström's, and some may have Bing-Neel with or without Waldenström's. How often does Bing-Neel syndrome happen? Well, given how rare Waldenström's macroglobulinemia is, Bing-Neel is even rarer. It is a subset of these patients, and I believe that it's probably underreported. I find the more you look, the more you're likely to find it, but finding it isn't always easy, needs specialist testing. So I believe that although it's reported to be in about 1% of all patients with WM, probably there's more of it, but it's not symptomatic, and it only comes to light when patients present with relevant symptoms. There are a number of reports in the literature, and those reports are building in number. I guess the most prominent recent publications have come from cooperative groups reviewing multi-center experience. And I guess there are a number of features related to Bing-Neel, which is how does it present, how does it relate to Waldenström's? Well, it can actually be a presenting symptom of WM. And you can see that the published experience puts that anywhere between 15 and 36%. So in other words, patients may present with central nervous system symptoms in the absence of Waldenström's being presenting first. And when they are worked up, they are found to have a systemic burden of disease in the bone marrow as well as central nervous system disease. It can actually be present without any evidence of systemic Waldenström's as well, although that's relatively rare. And it can happen when Waldenström's has previously been known about and been treated. So it's basically the same disease but operating within another compartment. Usually it does present as a feature of relapsing disease. But as I mentioned, it may occur at first diagnosis, and it is characterized by the infiltration or invasion of the central nervous system and sometimes the peripheral nervous system, if you come back to that Venn diagram I showed earlier. And these are some lymphoplasmatic cells in the cerebrospinal fluid, CSF. And this is a picture of an MRI scan showing some abnormalities in the brain tissue and along the meninges, which is the covering of the brain, and lower down at the bottom of the spinal cord here. There are different ways of imaging Bing-Neel syndrome. The important thing is for it to be, for the right imaging sequences to be done, because there are many ways of doing MRI scanning, and also for the use of what's called contrast with a substance called gadolinium, which helps to distinguish between disease that is receiving a blood flow versus something that's hemorrhage or bleeding, for example. But the key thing is that it really needs expert interpretation by a neuroradiologist. Now, unfortunately, there aren't that many of those around. So if there is a suspicion of Bing-Neel syndrome and it's unclear from a smaller, perhaps less experienced hospital, it's really important for those scans to be sent to an expert hospital so that that can be reviewed. Typically, Bing-Neel syndrome progresses very gradually. I would say most people who are found to have Bing-Neel have probably had it for months or even years beforehand. And there is often a considerable delay between the initial symptoms and the diagnosis. In a study, the median time from first symptoms and the diagnosis was about 4 months, but in a fifth of patients, it was more than 1 year. And as I mentioned before, Bing-Neel syndrome can occur even when the WM is in remission and when the M protein is absent or stable. So we have to keep on our toes with this condition. So we keep talking about the CNS, the central nervous system. Well, let me just take you through what exactly that comprises. So you can see from this picture here that this is what the central nervous system is, the highlighted part. So it's the brain and the spinal cord, which goes all the way down to the coccyx, or not actually the coccyx, but near there. And this is how the kind of computer of the body really communicates with the rest of the body through roots that come from the spinal cord down to the very extremities of the body, because some nerves do have to connect in some form to every part, every muscle, and you have to get sensation. So some of the longest nerves come all the way down to the foot, the sciatic nerve, for example. Others will have trunks which then branch off and form smaller nerves which then reach the finer tissues. So this, you can see a side-on view of the brain and the spinal cord. And I have to be honest, Bing-Neel can affect absolutely anywhere in this central nervous system area. So we just have to keep aware of unusual symptoms that don't quite fit in, especially if they are progressive. And what about the CSF? Well, the central nervous system sits in this cavity, if you like. It's housed within the skull and within the spinal column. And it's a very, very delicate tissue. And of course, it therefore has this fluid in which it sits called cerebrospinal fluid. And that's not just a sort of very basic fluid. It's a very important fluid which not only cushions this sensitive tissue against trauma, but also provides a huge amount of toing and froing of minerals and nutritional aspects, and supports the whole group of cells that helps to protect and nourish and clean the central nervous system. So that is really what the CSF is. And when we sample CSF using a lumbar puncture, we will generally take a sample from quite low down, called usually at lumbar 4 or 5, so that we avoid the spinal cord and go below it and therefore get fluid through a needle via a local anesthetic. Occasionally, a nerve root may be poked, and therefore people can get some pain down the leg temporarily, but this is usually a very temporary phenomenon and doesn't last for long. The other thing to highlight about the brain and the spinal cord or the central nervous system is that there is this so-called blood-brain barrier. Now, as I mentioned, brain tissue is extremely delicate. It obviously functions at a very high level, and it is therefore protected by a barrier which consists of supporting cells which have what are called tight junctions. So you can see here, obviously the brain, all tissues have a blood supply, otherwise they wouldn't be able to be nourished, they wouldn't get the oxygen they need. So you can see here a blood vessel going through some brain tissue at a very microscopic level. There are these foot processes, if you like, from supportive cells, glial cells, which form tight junctions. So they are literally not just a physical tightness, but they are very, they like polices, these junctions police what can cross into the brain tissue. And this is really to protect the brain from the toxins that come into the bloodstream all the time. Other tissues can manage quite well, but the brain is protected. And so when the lymphoma breaches the blood-brain barrier, the question is, why does that happen? How is that allowed to happen? No one quite knows what makes some patients in Waldenstrom's develop central nervous system involvement. It's not really understood. But somehow the cells of the LPL cells somehow breach this barrier and enter into the central nervous system and set up home, in effect, in the central nervous system and can build up there. Similar barriers exist over all peripheral nerves as well, but as the smaller the nerves, the more distant they are from the brain, the less stringent is that barrier. But you can kind of understand that it's just a matter of degree, but the brain has the most protective environment of all. The other thing about the blood-brain barrier is that when we treat Bing-Neel syndrome, we need chemotherapy or treatments that will cross the blood-brain barrier and get in where it is required. So those are the two main features of or important factors about the blood-brain barrier. So what are the symptoms of Bing-Neel syndrome? Well, as you can see, the brain gets up to all sorts of things at all times. It's very, very busy, and therefore the symptoms can be pretty much anything that the brain is doing that is going wrong. So clearly the brain does a lot of, it oversees a lot of motor functions, in other words, muscle movements. It oversees sensory functions, the receipt of signals such as pain and temperature and joint position sense, etc. So that you can understand that that's why some impairment of that particular tissue will lead to potentially weakness of muscles, loss of balance, impaired sensation. The brain, of course, also manages our thinking and our emotions, and therefore, if there is infiltration of the brain tissue, then these can be affected. And so people who have changes in their personality or thinking, loss of cognition, poor memory. Of course, there are many reasons as we age for other causes of this, such as dementia, whether it's Alzheimer's or vascular, etc. But in the setting of WM, and in the absence of any particular risk factors for these illnesses, I would personally have a low threshold for seeking out the possibility of Bing-Neel syndrome. The reason being that Bing-Neel syndrome is very, very treatable. And if you do find evidence of lymphoma disease in the brain, we can treat it. And we have certainly seen patients who have been extremely muddled and very dependent over time, responding well to treatment and actually coming back to full independence and functioning. And it is so gratifying to see that happen. And that is why I think, we must make every effort to look for Bing-Neel syndrome, because it's so treatable. So I think the key message from that point of view is that if people with WM develop symptoms of from the brain, if you like, brain dysfunction, it is worth the thought of Bing-Neel being considered, because as I'll mention shortly, the testing for Bing-Neel is relatively straightforward. You do need scans and lumbar punctures, but in the grand scheme, that is extremely doable and manageable. And it's certainly, there's everything to play for. So I think it's important to look for this. So the possible symptoms of Bing-Neel syndrome include, as I mentioned here, as you can see from reports, altered thinking, memory loss, facial weakness, paralysis, unsteady walking, headache, pins and needles, seizures, nerve pain, psychiatric symptoms, blurred vision, hearing loss. So just about anything, can. If anything develops of these sorts and are not explained by other testing and are persistent or progressive, then they should be looked at in more detail, usually through referring to a neurologist. Now, not all neurologists are familiar with Bing-Neel syndrome, so it's important to kind of nudge them into wondering about Bing-Neel syndrome, and hopefully they'll check into it and look into it and do the relevant tests. So how do we diagnose Bing-Neel syndrome? First of all, as I mentioned, and I keep saying this, we have to suspect the diagnosis, because really if you don't suspect it, you're going to kind of walk past it or misinterpret the findings and not find it. So if there are changes that are suspicious for something going on in the central nervous system, so for example, problems with communication or hearing, memory dysfunction, confusion, changes in personality, problems with balance, nausea, vomiting, drowsiness, blurred vision, seizures, etc. These symptoms do sound very alarming, but I'm just saying that if someone develops these and they continue to happen and they are unexplained, it's really important to think about Bing-Neel as a possible explanation. It may not be. It may be a simple, straightforward explanation. Things like strokes and so on, TIAs, transient ischemic attacks, these things can happen. Peripheral neuropathy, of course, can cause balance problems and numbness and weakness and so on. So I'm not saying it's going to be that, but think about it and have a proper workup. It's very important then to carry out some appropriate imaging, and the imaging of choice is magnetic resonance imaging, which is available to most people. There are some contraindications to MRI, including people who have a pacemaker, cardiac pacemaker, or implantable defibrillator, or any retained bodies in their brain, for example, like shrapnel or something, which is relatively unusual. But for the most part, MRI is possible and should be done with contrast so that we can highlight areas, because sometimes when you don't give contrast, you don't see those areas very clearly, and expert review. If MRI is not possible, then one can use CT of the brain, but the sensitivity is less good, to be honest. And, obviously experts can take a view, but it's less good than MRI. And you might say, well, what about PET-CT? Well, the thing about PET-CT is that you're certainly using FDG, the typical dye used for PET scanning in lymphoma, is that it is a glucose-based dye, and that because the brain uses glucose exclusively for its metabolism, PET scanning always shows up the brain very brightly. So it's not an easy way to look for something going wrong in the brain. So yes, This needs to be specially considered by the experts who are working the patient up with BingNeel. But that is the investigation of choice, and it should be done before the lumbar puncture, because if you do a lumbar puncture on someone and then scan them, you get some irritation of the meninges, which is the covering of the brain, and that can give you false positive results for weeks after, actually. So it's important to do the scan first and then the lumbar puncture. The other thing about a scan is it will show if there's any increased pressure within the skull, because if there is such a thing going on, it can be managed if it's known about, but it's not possible, or it's not appropriate to do a lumbar puncture if there is increased pressure within the skull. Which brings me on to the lumbar puncture. This is a way of obtaining this CSF that I mentioned from around the spinal column, lower down, so that we can simply literally put a needle in between a couple of vertebral bodies and obtain fluid which just drips out of the needle into a pot. You don't need too much. I mean, in some ways, we tend to take decent volumes so that we can do proper analysis, because we do look for whether there are cells present. Now, normally there shouldn't be any cells in the CSF, but sometimes you may get a blood tap because there are a lot of blood vessels around the lower part of the spine. If you get a blood tap, then you may see red blood cells in there. And if you then see red cells, the white blood cells may simply be a contaminant from the peripheral blood. So that has to be taken into account. If we, of course, see lots of white cells present and they are lymphoid in nature, then that is highly suspicious for BingNeel. But other things can cause high white cells, such as infections like meningitis, etc. The symptoms of meningitis are usually different, however. There's usually often a fever, there's often neck stiffness, which is not something that's common in Bing-Neel syndrome. So it's a slightly different category. But some chronic meningeal infections can cause raised lymphocytes, such as tuberculosis. But again, in the context of WM, the key thing really is to look for what are called clonal cells. And we do that by looking at putting the cells through a flow cytometer, which labels the cells with antibodies against CD20 and CD3 and 4 and so on, to try and identify whether these cells are lymphoma cells, whether they are clonal cells, because that helps us to identify whether lymphoma is present. It is also possible and important, actually, to do molecular testing on CSF cells, because if we find the MYD88L265P mutation, that is a really helpful confirmation of possibility of Bing-Neel syndrome. We can also look at the protein in the CSF, because normally there is a certain level of protein in the CSF, because proteins are there to help look after the brain. But if there's a great elevation of protein, then either there's some inflammatory process going on, or it could be a feature of Bing-Neel syndrome. And certainly in our practice, we actually do, we look for IgM levels in the CSF and test that relative to the IgM in the blood, and work out what's called an IgM index to see whether it is much more raised than it should be, bearing in mind that IgM in the CSF is a much lower concentration than in the blood, so there's a calculation that needs to be done. So if CSF analysis is informative, then that is great. It gives us confirmation of diagnosis, it gives us some idea of the burden of the disease in the CNS, but not a total picture. If on the other hand it's negative, then, and you are still really suspicious that there's Bing-Neel syndrome, or indeed if there are some features on scanning, then it may be necessary to do a biopsy of brain tissue or of the meninges if they are showing up brightly on the scan. This is something that's done by neurosurgical colleagues under anesthetic. It's a short operation, but if it's needed, it's needed. And of course, in expert hands, it is a rather straightforward operation, although neurosurgery always sounds very scary. Many of our patients have been through such procedures, and that has helped us to treat them effectively. And how do we treat Bing-Neel syndrome? Well, first of all, a bit like Waldenström's itself, treatment should only be offered to symptomatic patients in whom you have a definitive diagnosis of Bing-Neel syndrome. We have had some patients who have had CSF taken for whatever reason, and we find evidence of Bing-Neel, but actually when we evaluate them, they are not symptomatic in the least of central nervous system symptoms. So what we have elected to do is not treat them and simply observe them and keep an eye on them and say to them, look, if things change, then you will need treatment that's directed against the CSF and the CNS. So it's important. Symptomatic patients. But to be honest, most patients with Bing-Neel syndrome, when they present, do have symptomatic disease. That's why they're investigated. What about the goals of therapy? Well, a bit like the Waldenström setting, Waldenström's is an indolent disease. It's not regarded as curable, but can certainly be pushed down to a very low level so that it keeps out of mischief. So the goal of treatment is not to realistically to eradicate every last cell, although we try to reduce the burden of cells in whichever compartment as low as possible. But the role is to improve functioning, well-being of the patient and the outcome for patients. And this sort of improvement can span many, many years, decades even, in our experience. I guess what it comes down to is treating the patient appropriately. And that is something that is a matter for research and review and analysis as we speak. So, in some cases, for example, patients may still have evidence of residual disease in their CSF or even residual changes on the scan, although sometimes that is just scar tissue. So if you use a very highly sensitive tool such as MID88 mutation testing, you might see it still present even after you've apparently successfully treated patients for their Bing-Neel syndrome. The other thing, of course, to think about is, what is the state of the whole disease? How active is the WM versus the Bing-Neel syndrome? Because if both are active, then you need to target both compartments. If, on the other hand, the mainstay of problems is the Bing-Neel syndrome, then that probably takes precedence over the WM side of things. So these are the decision-making processes we go through. Now, if someone has very active CNS problems that need urgent treatment, we do weigh up the use of various agents that are known to be effective in CNS disease. Two commonly used treatments for central nervous system lymphoma, of which there are many other types, to be honest, include a treatment called methotrexate and cytarabine or cytosine arabinoside, or Ara-C. These are different names for the same drug. When these treatments are given in high dose, they cross the blood-brain barrier and they can treat CNS lymphomas. However, they are more intensive treatments and have to be given carefully, typically as an inpatient. So we do weigh that up on a case-by-case basis as to the amount of Bing-Neel that we need to treat, how badly off the patient is, whether they need a rather aggressive approach to try and reverse the damage, or whether we can be a bit more gentle and slow and steady with the treatment. Some traditional chemotherapy drugs do cross the blood-brain barrier, although they're not used typically for central nervous system disease. So these include, I guess, rather outdated treatments like fludarabine. Bendamustine, of course, is a very current treatment, and it has some characteristics in common with fludarabine and cladribine. And yes, it does cross the blood-brain barrier, and there have been a few reports of some good responses in Bing-Neel, but it's not. It's more of a systemic disease treatment. Rituximab is generally included in any of these treatment choices because it's clearly it's a very potent B-cell lymphoma treatment. And whether or not these treatments, whether or not, for example, rituximab crosses the blood-brain barrier, a bit open to debate. Probably it does. It is a sort of an IgG molecule. You could argue, though, as well, that the very fact that there is Bing-Neel syndrome, if there's disruption of the blood-brain barrier, then hopefully the treatments will cross over. There are reports that proteasome inhibitors such as bortezomib or Velcade can also cross the blood-brain barrier, so they can be used potentially. And of course, BTK inhibitors. There are a number of reports of both ibrutinib and zanubrutinib and pirtobrutinib of treating Bing-Neel syndrome. So this is something that we use in cases. Thing to remember, though, is that BTK inhibitors are more slow and steady treatments. So my own opinion is that if someone does have very rather aggressive, damaging disease that is really impeding them, and if they are fit enough, I tend to at least start off with some higher dose chemotherapy in the form of methotrexate and cytarabine. And after 1 or 2 cycles, reassess everything, including the CSF and the scans, and consider then transitioning onto a BTK inhibitor to carry on the process, and of course treat the systemic compartment, the bone marrow, if that is relevant. So these are the options. There's no consensus as to what the best treatment is, to be honest. It is a work in progress in many centers across the world. I would just add about these so-called novel therapies, like, well, they're not that novel anymore, but BTK inhibitors. My own view is that, they are truly excellent in many ways and are a step forward in the treatment of WM without a doubt. But I still think we have to be assessing every patient individually as to what is in their best interest. So I think we're all very anxious to see how these novel therapies work, and it's brilliant that more and more of them are coming online. But I still think some of the older traditional treatments have a role to play in the setting of WM and BNS. So, as I mentioned, BTK inhibitors can pass the blood-brain barrier, but the CSF concentration is much less than it is in the blood. So, larger doses than is typically used may be necessary, but in many countries that wouldn't be possible because dosing is rather specific for disease type. So when you've been diagnosed with Bing-Neel and have had treatment for it, what is the outlook? What's going to happen? So look, a little table here to show that people have analyzed. These are some of the larger experiences, 44, 34, 28, 35 patients. I think the key thing to remember with these publications is that the treatment was quite mixed, except in the Castillo paper where it was exclusively ibrutinib. Median follow-up is somewhat variable, so 55 months in the Simon paper. Castillo, this was the mixed experience of chemotherapy, 30 months. We have just submitted our own experience of 35 patients to the EHA meeting, and in it we talk about our tailored approach of using chemotherapy followed by BTK inhibitors, for example, and our median follow-up is 26 months. You can see that overall survival rates are very, very good. Now, bear in mind that in the 2015 experience, some of the patients, because the median follow-up is 55 months, some would have been diagnosed a lot before that. So I think we should take the overall survival rate with a slight pinch of salt, because since the early phase of this experience, treatments moved on. There are many more options, particularly in the form of BTK inhibitors. There's more experience, there are more sophisticated diagnostic and follow-up techniques. So, I think we need to be careful when assessing these data. What I would say, though, is that people respond very well in general to treatment. The vast majority of patients will respond well with, an improvement in their well-being. It makes sense that patients who perhaps can tolerate more aggressive therapies might do better if that's what they need. You can see that in one series, previously untreated patients people who had previous treatment for WMs didn't do as well as those who'd never been treated. You could think about that as fresh disease that's never seen chemotherapy, if you like. On the other hand, the other paper showed that there was no difference in those who were previously treated, but this was using ibrutinib. So I think the data is quite a mixed bag, and I think in the coming years we'll get a better understanding of how people do with longer follow-up. My own experience is very positive. People with BingNeel, for me, it is just another expression of Waldenström's. It doesn't immediately mean it's a disaster. It does, by any means, it is just something that we need to manage a bit differently. And our own experience has been good. I mean, patients do well. We continue to tailor the approach to the treatment. One has to be quite patient with improvements in neurological dysfunction. But I've seen really good results in the majority of our patients who are doing very well and continue to do well. So I think if you go online and look for CNS lymphoma, you will see a lot of gloomy statistics, but a lot of that refers to what is called primary CNS lymphoma. And that refers to what is called high-grade lymphoma, diffuse large B-cell lymphoma, which BingNeel isn't. So people who have high-grade lymphoma in their central nervous system, that is more of a challenge. If you have WM in your central nervous system, which is otherwise known as Bing-Neel syndrome, I believe it's very treatable. I think we can do well with it over many years. It's not a problem. It does need a tailored approach. It needs a bit more doing with scans and LPs and so on. But it is something that you can do very well out of. So the take-home message is that every patient with WM who has atypical and unexplained neurological symptoms that are progressing, we should consider Bing-Neel syndrome. We should move to getting an MRI scan, preferably with contrast, of the brain and the spine, ideally. We should also get a lumbar puncture with extended testing and clinch the diagnosis. Once we've done that, then, I would say that it's good to seek advice from a specialist center to try and get the best treatment plan arranged for the patient. But yeah, stay positive. This is something that can be managed as is the case with WM. And with new therapies around, things are looking good. So with that, I'd like to thank you for your attention, and I wish you well. Enjoy the rest of the session on BingNeel.